YNF NSI Exam Online. We are waiting for the candidates to join. Dr. Avinash has joined. Dr. Vedang. Dr. Vedang, are you there? Also waiting for Dr. Apinder Preet and Dr. Darpan to join. So we'll wait another 5 minutes and then we start. Good evening, Dr. Darpan.
गुड इवनिंग डॉक्टर प्रशांत, कैसे हैं?
बस ठीक सर. We are waiting for Dr. Apinder Preet to join and
Right.
Avinash has joined. Dr. Vedang, are you there? Vedang. I think Vedang has joined. We'll start once Dr. Apinder Preet has joined, sir.
Right.
Who is presenting first? Dr. Vedang, are you ready with your presentation?
I'll present first, sir.
Okay, so you can start your screen sharing.
Screen sharing, just a minute, sir.
Yeah, no problem. You have the green button down, share screen.
Prashant, just tell them the format once.
Yeah.
Just to be sure.
Dr. Vedang, you know the format, and Darpan sir, the format is when the first presenter presents the case, the questions go to the second person. If he's unable to answer, the question bounces back to the presenter.
Correct.
And we have 45 minutes each for the long case and then OSCEs.
Sir, I can share my screen now.
Yeah, please do.
So it's showing host as disabled participant screen sharing.
Navneet ji, can you please? Now you're co-host
Navneet
now.
ji.
You can. Yeah, he's co-host now. You can start. Try again once more. Yeah, it's showing.
So I'm audible, sir?
Yeah,
Just
you are
a
audible.
second. Dr. Apinder is not joined.
It's okay. Darpan sir, can you take the lead on this, please?
Sir, you are
Darpan
muted,
sir.
Darpan sir.
Yes,
Hello.
sure, we can do that.
Yes, by the time sir joins, please take the lead on this, and Vedang can start presenting for the interest of time.
Fair enough. Yes, please.
Sure. Vedang, please start.
So,
Avinash, you're ready, right? Dr. Avinash?
Yes, sir.
Okay.
So
Okay.
hello guys, I've joined.
Abinder sir, I think Darpan sir can take the lead on this, and then you can take the lead on the second one.
Yeah, fine.
Presenting. Sir, yes. Okay, sir.
We decided otherwise. Let Dr. Apinder.
No, it's okay. It's okay. Darpan, you go ahead with this.
Right, sir.
However
Fair
you
enough.
feel, sir. However.
Right.
Vedang, go ahead, please.
Please start.
So I'll be presenting a case. My patient, Mr. ABC, gentleman of age 23 years, is a resident of Bihar, Hindu by religion, shopkeeper profession, and he is right-sided and reliable as an informant. Uh, So he presented with the following chief complaints. First was a short neck and restricted neck mobility since birth. Then neck pain from last 3 years, increase since history of trauma. Weakness and stiffness leading to difficulty in walking since last 2 years. Tingling and numbness in all 4, and imbalance while walking since last 6 months. The patient was having a short neck and reduced neck mobility since birth and was shown to local practitioners in early childhood, and his family was reassured that he had no symptoms at that point of time. Patient was apparently all right when he started to having neck pain 3 years back. Patient does not exactly remember the moment when the pain started, but he correlates it to an incidence of fall from ground level. That is 3 years back while picking up a stack of goods. Now the fall was minor with no history of loss of consciousness or weakness. Following the fall, he had no recall of any goods falling on his head or neck. Now the pain was dull, aching, and tight, insidious in nature, and progressively increasing. The pain was initially mild in nature, but it increased to moderate intensity in last 2 years. The pain was localized to the back of the nape and also involved the back of the head. So initially the pain was aggravated on activities like lifting objects at work or to keep in the upper shelf while transporting goods. Now it is continuous throughout. There is partial relief with rest and analgesics, but the pain has no diurnal variations. On direct questioning, the patient reported that the pain increased on flexing the neck and movement of the neck. On asking, he gives history of sounds such as clicks during neck movement. Now, there is no effect of coughing or straining in causing increase in the pain. Patient also complained of weakness in all 4 limbs, which he had ignored in the beginning. Then he started noticing difficulty in writing his accounts in the shop with his right hand, following which he noticed he had difficulty in lifting goods and materials with his right hand, which included keeping goods on top shelves. Now he started using his left hand to operate his mobile phone and also do activities such as combing his hair. To be noted, sir, he commuted to his shop using a motorbike, and as the time passed, he began to notice a difficulty in driving his motorbike. He faced difficulty in accelerating using his right hand, also faced problems in braking with his right foot, and braking with his right hand. In the beginning, he did not have any similar problems with pressing the clutch, but over the time, as the time progressed, he started having difficulty in pressing the clutch also. Sir, as time progressed, he had difficulty in managing coins during transactions with customers and difficulty in buttoning and unbuttoning his t-shirts. He had stiffness and weakness in his lower limbs, which he noticed when he had difficulty in getting up from squatting position after using washroom. He also noticed difficulty in wearing his chappals and positioning his feet in chappals. He also complained of slippage of footwear on multiple occasions. Later, he also complained of difficulty in turning in his bed, difficulty in getting up from sitting position in his bed when he's lying down. He does not complain of any sounds of fasciculations. Now, since past 6 months, he has progressively complained of imbalance in walking, which is exaggerated while walking on uneven ground, when he has to walk to nearby shops to get some goods. In the past 2 months, he has had history of 2 small falls while walking, especially while getting local goods by the foot when it is dark, and especially in night. His co-workers say he has had episodes of fall in his bathroom while washing his face. His co-workers also say that he walks very cautiously looking down at the floor and is always worried that he will fall. He walks slowly, but he can walk without support and sometimes drags his foot. He also complains of tingling in all 4 limbs since last 1 year, which started in his right upper limb, moving to his right lower limb, and now is in all 4 limbs. He complains of electric current-like sensation more over his right side compared to the left side, which is exaggerated on defecation, or when he bends his neck forward. And the pain is relieved by taking rest or lying down. Currently, he does not complain of electric shock-like sensation over his spine when he flexes his neck. He also has complaints of numbness on his right side of the body and face compared to his left side. He says he has difficulty in identifying hot and cold water with his right side of the body, and he gives bilateral decrease in sensation of clothes that he's wearing more on the right hand side where he wears his wristwatch. Also, he complains of reduced sensation over his face more on the right side compared to the left, especially during shaving. He has no decrease in sensation in perineal area. No painless cuts or burns in his arms or legs. When asked specifically, he noted he has less sensations of the pillow when he is sleeping. So, sir, there's no history of cuts and burns, like I've mentioned. Patient does not report of any sensory deficits in perineal region, like I've told you, so while washing. In cranial illness, the patient does not have any loss of taste. There's no history of dysphagia, dysphonia, or dysarthria. There's no history of facial palsy. There's no history of vision loss, blurring, diplopia. And there's no history of voice changes. There's no history of decreased sweating over upper part of his body, no history of ptosis. There's no history of shortness of breath or difficulty in completing sentences. There's no history of waxing and waning type of symptoms of the pain. There's no history of trauma. There's no history of any difficulty in urination, increased frequency or hesitancy or poor stream. There's no history of constipation or impotence. There's no history of fever, night pains, or weight loss, or any recent weight loss. And he does not complain of any having multiple swellings in his body or any deformity in his back. There's no significant past history, sir, and he does not give any significant family history. He's been taking medications for the treatment back pain, that's all. And there is no significant birth history also. So I would like to note the current functional disability of the patient. The upper limb, he's able to feed himself independently, but has difficulty in unbuttoning and buttoning the shirt more with his right hand. In lower limb, he is able to walk independently, but difficulty in getting up from squatting position. At the same time, he has difficulty in turning in his bed and getting up from sleeping position. Ball bladder currently, according to his symptoms, he's saying is not involved. So I'd like to present the summary. And 23-year-old shopkeeper having congenital short neck presented with post-traumatic local neck pain for 3 years, worsened with movement, with an acute onset asymmetrical progressive spastic quadriparesis, right more than left since last 2 years, with tingling and decreased sensation loss below the occiput over the right side of the body of more than left and on face since 1 year, ataxia since 6 months, and no evidence of ball bladder and cerebral and cranial nerve involvement or autonomic system. So from my perspective, sir, the substrates involved are the spastic quadriparesis is towards bilateral corticospinal tract, a sensory ataxia is towards posterior column, numbness is spinothalamic, and facial numbness is the spinal nucleus of the trigeminal nerve. So from my perspective, sir, the nature of the lesion is myelopathic, and the horizontal localization on the basis of history is extradural, and vertical localization will be from CVJ to C2 to C4. And other complications that can happen with this history is that there can be presence of syrinx, and etiology, it looks like congenital plus traumatic.
Okay, are we done with history?
Yes, sir.
Okay. Dr. Avinash.
Yes, sir.
Okay, any other thing which you want to ask Dr. Vedang? Any other information which you would need on this case?
Dr.
You have
Avinash,
heard the
you can speak the
history,
cases,
you
so-
have seen his summary, also the substrate analysis and the disability assessment.
Yes,
So
sir.
anything else which you would want to know in the history?
No, sir.
So you agree with the this thing summary?
Sir, yes, sir.
You will be able to make a differential based on this summary? Okay. What does short neck since birth signify?
May I answer, sir? Sir, may I answer?
Let him answer first.
Dr.
then-
Vedang, hold on. It will come back to you in case Dr. Avinash is unable to, okay?
Yeah.
Could be a congenital cause, sir.
That's
Congenital.
okay. But he has very specifically brought out that they did approach a practitioner with the same complaints, and he said there is nothing to worry about, and they came back.
Yes, sir.
So, and he also mentioned along with the short neck since birth, he also gave history of restricted movements of the neck.
Yes, sir.
So First of all, do you want to know anything else about it? And if no, then what do you think it would be? Congenital, yes, anything which is since birth, it will have a congenital involvement. But what is the involvement we're talking of?
Even I would like to ask, yeah, same. So as Dr. Darpan is asking Dr. Avinash that, are you able to listen to me?
Yes, sir.
So what Dr. Darpan wants to ask you that is there any congenital anomaly which can aggravate these symptoms, which can contribute to these symptoms? That there is a pre-existing congenital anomaly and the trauma has aggravated those symptoms, has worsened those symptoms. Do you understand now?
Yes, sir. Sir, Klippel-Feil syndrome.
Okay. So, Dr. Vedant, did you mention about the neck and the body ratio?
That I'll talk about in the examination. Sir.
Examination.
Okay, and yeah, okay. Anything else in the history, Dr. Avinash? Yeah. Over to Darpan. Yeah.
So what do you feel would get aggravated by the fall, which he said? How is that? How has that aggravated? What is the mechanism of aggravation of the so-called congenital involvement by the fall? You understand the question?
Yes, sir.
Dr. Avinash?
Yes, sir.
Okay, so whatever congenital deformity we are talking of, how has the fall from, say, ground level, what has it done to it? Why has he become symptomatic in the last, say, 3 years after he had a fall, which was a trivial one? He mentioned that there were no features suggestive of head injury or something.
Compression.
Compression of? You have to be more specific. Compression of? Okay, no problems. Dr. Vedang, did you mention about the sequence in which the limbs got involved? Because you did say quadriparesis, but in your history, it is not very clearly brought out as to in which order the limbs got involved.
So I've spoken that, sir. The problem is that he's saying that his right upper limb got involved first, then followed by which he said he had right lower limb and he's noticed his right lower limb, and then followed which he noticed his right upper limb and right lower limb, left lower limb, left upper limb, left lower limb. But the history
that's called as
sir, the crossed hemiparesis, quadriparesis.
No, that's not called as a crossed hemiparesis. Crossed hemiparesis would be right upper limb and left lower limb.
So U-shaped,
right lower limb. So Dr. Darpan is asking you the sequence. You have the U-shaped sequence, right?
U-shaped sequence, yes,
so
sir.
What is the name of that phenomenon? That's what.
Ellsberg's phenomenon, sir.
Okay. Can you explain why it happens?
Sir, it happens because of an extradural extramedullary compression in that case. So that will happen when the compression is coming from the outside and the distribution of the corticospinal tract is such that it comes from the CTLS, that is from inside to outside, it happens from CTLS. So if the compression is coming from outside, the patient will start having lower limb symptoms from one side, then will progress to upper limb symptoms of that side, and then upper limb symptoms of the other side, and then lower limb symptoms of the other side.
No, but if CTLS compression is there extradural, then the lower limb symptoms will come first. No, but patient has upper limb symptom. So how can an extradural lesion can cause?
No, so in this case, that's what the history was particularly not in correlating to the exact phenomena, because as I said,
it is correlating very well. There's some, I mean, your explanation is not right. That's what, please continue.
Dr. Vedang, you understand? If the right upper limb is getting involved first, how do you explain?
Sir, I can explain by saying that the patient must have a syrinx, and that is why the compression must be happening because of intramedullary.
In that case, patient will have bilateral upper limb involvement first.
Yes, sir.
So how come one upper limb and then one lower limb and the contralateral lower limb? That's a classical Ellsberg phenomena, right? So there's some other explanation to it. Dr. Avinash can also answer it.
Dr. Avinash, can you explain this?
Explain. Uh,
You understood the question?
Yes, sir. You saying
This is
that
about the order in which the limbs got involved in this patient.
yes, sir.
So it is the right upper limb followed by the right lower limb, and then the left lower limb and the left upper limb.
Yes, sir.
So either we say that it is a, how do you explain it? Extramedullary, intermedullary?
By the Earlsberg phenomenon.
Correct? No, that's the name. How do you
Yes, sir.
explain the order of involvement in this patient?
In pathophysiology, that's what that means.
Pathophysiology.
So Dr. Vedang, what you could have done is you could have drawn diagram of the crossing of the fibers at the level of CV junctions. Where does the upper limb and the lower limb fiber cross? Dr. Pan, please.
Where does the upper limb fibers cross? Proximal to the lower limb or distal to the lower limb?
Sir, the upper limb fibers cross proximal to the lower limb, sir.
So if the compression is there at this vicomedullary junction where the upper limb fibers have crossed and the lower limbs haven't crossed, then what will happen?
Then first upper limb will be involved, sir.
You understand that?
Yes, sir.
Okay, so
yes,
this
sir.
you must. Okay, did you give a history about breathing complaints?
Yeah, no, sir. I asked in negative history, sir, that he does not have any difficulty in breathing or completing his sentences.
Okay. Right.
So understand what Dr. Darpan is saying, that see if the compression is the level of just at the level of the crossing of the upper limbs, then patient will have symptoms of central cord syndrome. If we are at the level of the lower limbs, then we'll have symptoms of lower limb weakness. If on the one side it is involving, it can cause hemiparesis, it can cause cruciate hemiparesis, it can cause monoplegia, biplegia, diplegia, everything. All symptoms can happen because of a CV junction compression.
Sure.
So only when a particular form of thing is involved, that when at the level of crossing fiber of the one limb, the CV junction compression is there, and then the compression goes down to the lower limb, then to the opposite lower limb. That is a phenomena called as Ellsberg, which happens in a only subset of patients.
Sure.
Cruciate hemiparesis, upper limb paraplegia, paraparesis, monoplegia, all symptoms can be there in CV junction compression, depending at which level the compression is at the level of crossing of the upper and the lower limb fibers.
Sure.
Darpan is asking about respiration. Please continue.
Okay, that he has answered. How is this sensory ataxia temporally related to the weakness in this patient?
Sir, sensory ataxia related to the weakness?
No, temporally related. I mean, which came first and which came later on?
So according to him, weakness came first, sir.
Okay.
And then it was followed by, then he noticed difficulty in walking.
And the difficulty was more when he was walking in the dark and he had a fall.
Yes, sir. Particularly, he says that at dark and in uneven surfaces, though I questioned in more detail regarding the particular history from which, walking in small, narrow spaces or trying to find switches in the switchboard at dark, he could not elicit the same one, but he did say that he had difficulty in walking in night.
Dr. Avinash?
Sir.
What would it, what would you infer when he says that he has a difficulty in walking in dark, or he stumbles, or he falls down? What does it mean?
Sir, involvement of the dorsal column, sir.
Okay, and why would that happen? Why would involvement of the dorsal column in a compressive pathology translate into difficulty in walking in dark places?
Sir, in a dorsal column, if the dorsal column is affected, the visual compensation is affected, sir.
Compensation. Is that the word?
Uh, the as in like the visual input, sir.
Okay, right. Visual cues or visual inputs are not there. So what happens?
Sir, that causes the involvement of this I mean the loss of this visual inputs causes difficulty in
No, I think you're getting confused. See, try to understand. When you're saying he has a fall in the
yes,
dark,
yes,
is
sir.
the fall because of stumbling or is the fall because of imbalance?
Imbalance, sir.
Right. So instead of saying that loss of a visual cue, because this guy is seeing as well as he was seeing before, right?
Yes, sir.
Dr. Vedang, is there any visual?
No, no, sir.
No.
No, sir.
Right. So
Mhm.
there is nothing of, say, reduction in visual acuity, neither on history nor on clinical examination. So this patient is seeing as well as he was seeing before,
Yes, sir.
right? So whether it is in the light or it is in the dark, he's seeing as well. So what is it that is causing imbalance when he's in the dark? So as you
So,
said, visual cues are now absent. So what happens? He develops imbalance because,
so because of the dorsal column carrying the proprioception and the joint position, which
right?
is absent, which becomes affected in the following patient, the patient relies upon the visual cue to manage the stability. The
Mhm.
moment the visual cue also goes, the patient's joint position and the proprioception is lost, and that's why the patient falls.
What is the third thing which is responsible for balance?
The
Vestibular system.
vestibular system.
Right.
Mm.
So the visual cues going away, he will develop imbalance if he has
Disturbance in the
dorsal
proprioception
column,
or
joint
the
position sense, and
vestibular system, sir.
no, vestibular is okay. Vestibular is fine. In sensory ataxia, when you say compression of the dorsal column, in addition to proprioception and joint position, what else is going? He also complains of reduced touch sensation all over, right?
Yes, sir. Fine touch also.
Okay, and numbness, when you say in your substrate analysis, what was the extent of this numbness? Tell Dr. Avinash and then he'll explain it.
So he's complaining of numbness, which is starting, which is all over the body, which started from the right side, but it is till the neck.
Starting
Till
from
the
the right side and till the neck.
it started from the right side. Now it is on all four limbs. He complains of numbness on all four limbs, but
Right more than the left.
right more than the left. But it is also there in the back region till the neck. He's saying. So I
And
also
why does,
asked this
what do
particular.
you, okay, sorry, please
Uh,
complete. Please complete.
So I also mentioned in the history, sir, that while sleeping, he said that he has difficulty in identifying the pillow. The nape of the neck also, I think, was involved.
That was in any case I was coming to you. What does that mean? When you say reduced pillow sensation or sensation of pillow?
So I think that the nape of the neck is involved, sir, in the numbness. So probably it is indicating towards till the level of C2.
He will not appreciate a pillow if he has numbness of the nape of the neck. Okay,
Yes, sir.
anyway, we'll leave that. What do you mean when you say nature of lesion is myelopathy?
Because the patient has myelopathic basically. If it's radiculopathic or myelopathic, I wanted to differentiate between that. I believe that the patient has spastic quadriparesis, so the lesion is towards the myelopathy, sir.
There is no pain.
You need to answer all these questions actually. Yeah. Anyways, yes, please let that continue. Yes.
Dr. Vedang, there is no pain.
Sir, pain, neck pain is there, sir. I've already described the neck pain in the beginning, sir. That is the primary complaint, sir.
And it has been the same ever since the fall 3 years
No,
back?
sir. It has been increasing. The neck pain has been increasing. Firstly, it was there only during some activity. Then it is currently there the whole time.
No, Dr. Darpan is asking you, so you've not mentioned about the substrate analysis about the pain. Is it radicular? Is it follicular? Is it musculoskeletal? Is it what?
Yes, sir. I've missed that, sir. Yes, sir. I've not mentioned the pain in the.
Dr. Avinash?
Sir, yes, sir.
What could be the reason for this pain to increase in intensity? First of all, why does he have pain? Because a pain which is post-traumatic is likely to subside within 4 to 6 weeks at his age, right? He's a young person.
Yes,
If
sir.
it was only a post-traumatic spasm or something, it should have gone in 4 to 6 weeks. Why is it persisting and why it has become severe over the last 3 years?
So because of the instability.
Instability?
And
Why will that cause pain? No?
Sir? Sorry, sir.
Why will that cause pain? See, we have asked you certain, it can be either radicular, it can be funicular, it can be musculoskeletal.
Yes, sir.
So what do you
He's
think
giving
of
you a
it?
hint.
We're giving you a hint. What do you think this pain is because of?
So as the history goes, sir, it looks like a funicular pain, sir. It's because he's saying it is not localized exactly, and it is
It is worsening with the moment. Why a funicular pain will worsen with the moment?
So that's what I feel, that the history of pain was having both the even the fact that the patient has external compression and that bony compression is causing the pain, and which is there at but the patient also has deep-seated pain. So I was wondering that it was having both the presentations.
Both the presentations means components. Which all?
Both the components. That the patient will have a funicular type of pain also and radicular pain. Both the things.
So then why your nature of lesion is only myelopathy? Then it should have been myeloradiculopathy.
Yeah.
Yes, sir. But then it was not shooting. There was no proper shooting type of pain, which was running.
No, you cannot have it both ways. I mean,
Sorry,
on
yes,
one
sir.
hand, you would tell me that it is radicular as well as myelopathic, but
Sir.
then you will tell me, no, it is predominantly funicular, so we'll keep only the myelopathy. Okay.
Yes, sir. I agree, sir.
But Vedant, what Darpan is saying that if we probably had a trauma,
sir,
the pain might be musculoskeletal.
Sir.
As the edema and the swelling and the pain subsided, so the pain is still persisting.
Yes, sir.
Understood that. So musculoskeletal initially was there, but then what was the predominant substrate which is causing the pain?
Yes, sir. So I believe, sir, that predominantly post the musculoskeletal pain, which had subsided in the first whatever 5-6 weeks that sir is saying, then I think it can be funicular, sir.
We don't agree to your funicular because the funicular is dull-licking, burning sensation, more of a dysesthetic pain, more of a dysesthesia than.
Okay, sir.
Can still be musculoskeletal because there is, if you think there is instability.
Okay, so basically,
which radical? By the way, which radical? Which radical? If you.
Sir.
Which radical you are talking about?
C2.
No, radicular pain. So
yes,
one
sir.
thing is Dr. Tarpan said that radiculomyelopathy should have been the thing if you would have
Yes,
said.
sir.
Which
Yes,
radical?
sir.
Which radical?
Sir, it can be from C2, C3 at that level, sir.
That question comes, what is this? Where does C2 supplies, where does C3 supplies? Yeah, that's what it is. Where does C4 goes?
So C2 will be near the nape of neck. C3, C4 will present towards the shoulder region. C5, C6, C7 will come towards the hand.
Suboccipital region. Or that one, please. Yeah.
So once you have said that facial numbness is because of the spinal nucleus of trigeminal, that's what you said, right?
Yes, sir.
Coming to the facial numbness, you said that it is probably because of involvement of the spinal nucleus of the trigeminal. So, Dr. Avinash, what is the extent of this nucleus?
Sir, till it's still C4, sir.
Till C4. I mean, where does it start?
From pons to C4, sir.
Okay. So you're seeing this substrate analysis in front of you?
Yes, sir.
Why do you think he has taken the vertical extent from CVJ to C2 to C4? Because all this, what is getting involved, can get involved at a C4 level also.
Yes,
if you
sir.
said that the distal end of spinal nucleus of trigeminal is at C4,
yes,
then
sir.
all this could comfortably be, say, a PIVD C3, C4? why should the vertical level go up to CVJ? There is no breathing involvement, and none of these substrates tell you that it has to be CVJ. Could well be C3, C4.
Sir, considering the sensory loss
of the
at the C2 dermatomal distribution, there is a involvement of the sensory loss, sir.
Sensory loss at C2. Okay. I mean, first of all, C1 to C4 or C2, C3, C4, the sensory levels are very ambiguous. You
Yes,
cannot
sir.
pinpoint that this is C2, this is C3, this is C4.
Yes, sir.
Right?
Okay, sir.
It is either trigeminal or then we come C5 is deltoid area. That is what is clear cut. Rest nape of neck, they are very fine lines.
Yes,
it's
sir.
not sacrosanct.
Yes,
So
sir.
that is one. Second, if it has to happen, the compression can cause syrinx there and can cause that similar loss. Okay.
Can we
Dr.
explain it
Vedant?
please, sir? Because the patient has the history of a short neck and is having some clicks also, then we can localize it to the CVJ, sir, on the basis of history.
But a Klippel field can have block vertebrate C2, C3, C3, C4, C4, C5. Anywhere.
Yes, sir.
So
Patient can have.
Does not fit into the criteria.
Yes, sir. It does not completely localize, but I was
Secondly,
asking.
when you say short neck and neck clicks, taking your diagnosis elsewhere, when I said then when you are doing substrate analysis, then you are not looking at those symptoms. I'm asking, with the substrate analysis, can you localize the vertical extent upper to CVJ? You have your substrate analysis right in front of you. With the spinal nucleus of trigeminal nerve, going till down below. Why do you put the upper vertical limit at CVJ?
On the basis of history, sir, I mean, yes, sir. I'll have to probably examine the patient to look for reflexes and get a better idea on that.
No, we'll come to the examination. Then we'll say what have you added after the examination. But basis on the history, we just discussed something. You remember that? The involvement of the limbs?
Yes,
that
sir.
Is what you can use here.
The decussation. So
that is what you can use here. Okay.
Okay, sir.
So in the history, apart from the substrate, because this is your objectivating whatever substrates are involved. In addition, by history, you can definitely mention that there is a pointer which is in favor of taking my vertical this thing.
Yes, sir. Because of the involvement of the limbs in that particular pattern, it's close to the decussation.
Right. When you say etiology congenital plus traumatic, Dr. Avinash, what does he mean? When he says congenital plus traumatic.
Yes, sir. Sir, a congenital condition which is precipitated by the trauma.
Okay. Please elaborate. You said Klippel field, right? When we discussed that short neck present since birth, you said Klippel field. So what complication or what aggravation will happen for the symptoms to get kicked in the way they have in this patient?
Sir, with the Klippel field, there is already a compressed spinal canal, sir.
So, no, I mean, this is almost the replay of the question which we asked some time back to you. Like, what is the pathophysiology? He had a fall, and then the entire cascade started. He was good till about, say, 20 years of age, with whatever short neck he had, whatever restriction of neck movements he had. He was good till about 20 when he had this fall, and that is when the entire cascade of the symptoms started. So what would have happened, or what would have gone wrong, or what would have got destabilized at that point of time, so as to say, for all these symptoms to start and then get aggravated with each passing day? Something you have to think of, no? This could not be without a reason.
Sir, atlantoaxial dislocation.
Dr. Vedant.
Sir, the patient is already having must be having you can say the cervical, the canal would be compromised already, sir, and because of the trauma, it would have.
Wait. We have only spoken of a short neck. Where does this canal compromise come?
No, so I was saying that if the patient is short neck, we're considering the patient have some congenital anomaly, which has probably a AAD or a platybasia or something like that, sir. In that case, the patient
Would
will
a platybasia get aggravated by trauma? That's not instability.
So, but congenital, I mean to say that AAD or basilar invagination, or in these situations, will it get? I feel it might get aggravated because of trauma.
Why?
So if there is congenital some anomaly, yeah, why? First of all, please, why? Yes.
So the local edema will happen, sir, at that area. Probably that is a venous congestion can happen at that area, which will exaggerate the symptoms.
Ligaments?
Ligamental,
not there?
Yes, sir. Ligaments can also.
See, you have to think of something. Even if it is a atlantoaxial dislocation, or it is, say, increased atlantoaxial distance, something would need to happen to that local area for it to get destabilized and give rise to symptoms. He has lived with that short neck for 20 years, right?
Yes, sir.
What restriction of movement did they complain of? That you have not elaborated. Since birth, you said he had restriction of neck movements. What do we mean by that?
Sir, while moving his neck, he used to say that he has to have a little bit of restriction.
All directions?
All directions.
Flexion, extension, lateral flexion, everything?
All directions, he was saying.
Okay, and why should that happen?
Sir, I believe, sir, the congenital involvement can have the syndromic involvement can be there, so that might have these.
So that will have restriction of neck movements?
So the ligaments can be spastic, can be tight, so that's why there'll be because of the congenital AED or something, there can be the ligament spasticity or ligament tightness can be there, which will cause these problems.
Okay.
I'll definitely read up, sir, about it.
Okay, and one thing I would like to ask, that if you have kept this local pain as a radicular pain, then why you are keeping it as an extradural? If according to you, neck pain is root pain, you mean, right? So why extradural pathology? What's the difference between an IDM, I mean intradural, extramedullary, and extradural pathology? Dr. Nikhil has raised a hand, I guess.
So the difference between the IDEM and EDEM, you're saying, sir? So in this situation, the patient will have radicular pain.
There's definitive asymmetry, right?
Asymmetry, yes, sir.
That goes in the favor of IDM, right?
Yes, sir.
So if you're attributing your local pain to radicular pain, then what makes you say it's an extradural pathology?
Sir, the other involvement of spasticity and all also is there, so that.
Understand what I'm saying? The major point towards extradural is local pain and tenderness, right? And
Yes, sir.
major point towards IDM will be a radicular pain or an asymmetry of the
Yes,
pain.
sir. Yes, sir.
So you're mixing the two things. Understood what I'm saying?
Okay, sir.
And on the other hand, you were saying it is a funicular pain. So it is a funicular, and then both goes out. And there's nothing to suggest extradural, right? Understood that? Yes.
Dr. Vedang, are you understanding this point?
Yes, sir. I understood, sir, that the pain for all the three extradural, intradural, and intramedullary have three different types, and in the history it's all getting mixed up, sir. I understand. So it
correct.
doesn't.
So in your history, you need to get it one side.
One-sided, right?
Either
sir.
you say funicular, or you say radicular and
Local.
asymmetrical.
Yes, sir. Yes, sir.
Sir, sorry to interrupt. Can we make it a little faster for
yes,
this
please.
examination?
Go on to examination.
Yes, sir. Thank you.
Dr. Vedang.
Sir.
Examination.
So on examination, sir, the patient has ectomorphic build with normal hair and skin, sitting on chair with and walking a stick by a stick, and pulse is 60 and BP is normal, sir, and respiratory rate is 18, chest span is 2.5, and hairline is normal, neck length is normal, no ulcers on trophic changes are seen, and no evidence of spinal dysaphorism, neurocutaneous markers, a high arch palate, webbing, scoliosis, gibbous, deformity, or cleft palate is present. In systemic examination on respiratory, trachea is midline, chest movements are normal, and single breath count is 14. And CVS examination is normal, sir, and there is no other the positive findings there, sir. In nervous system, sir, higher mental is normal, sir. Cranial nerve examination means all the cranial nerves were normal, sir. There was no involvement of any cranial nerve, sir. And this I've spoken in detail regarding the same. In motor examination, sir, the bulk was normal on both sides, sir. It was seen in arm, forearm, and thigh and calf, and the tone was spastic in bilateral lower upper limb and lower limb, sir. In power, sir, though the power was not showing a significant difference, sir, it was almost the same only.
Sorry to intervene, Dr. Vedang. You missed hand bulk, which is very important in CV junction.
Yes, sir. Yes, sir.
There is isolated hand weakness in CV junction normally. That's why I wanted to. Yeah, please continue.
Sir, in power, sir, I could not find much of the difference between the two upper limbs and lower limbs, and it was spastic, and it was around 4, sir. That's what I would consider in all joints and all movements, sir. During the reflexes, sir, the interscapular was absent, and the abdominal abdominal was absent, interscapular was absent, cremasteric was mute, and plantar was exaggerated. Upgoing. Whereas in the deep reflexes, sir, I thought deltopectoral was present. So that was one thing, sir. And rest all the reflexes were exaggerated, sir. In sensory examination, sir, again, sir, I mean, I've written, sir, but I don't, it was a little vague, sir, but it was showing that he was saying that his right side was having more sensory loss compared to the left side. He was pertaining to this thing again and again, sir. So, so in summary, sir, that 23-year-old shopkeeper having congenital short neck presented with post-traumatic local neck pain, acute onset, spastic quadriceps, tingling numbness, indicating the involvement of bilateral cortical spinal tracts, posterior column, spinothalamic tract, and spinal nucleus of trigeminal nerve, with pathology suspected to be motor region to be CMJ, sensory to be around C5, and reflexes at C2, C3, sir.
You finished examination?
Yes, sir.
Okay. So after examination, what do you feel, Dr. Avinash?
Sir.
What have we added, what we did not have at history in the examination? Or we are, I mean, almost the same? Dr. Vedang?
Sir, I think, sir, the fact that we have spastic quadriparesis, that has been clear, sir, and also, sir, the reflex, sir, the deltopectoral reflex getting present now shows that the level is above C3, at around C3. That was the involvement has started there, which is usually absent, sir, in normal patients.
So you have confirmed your spastic quadriparesis?
Yes, sir.
Because this you had in history also. In history, you
Yes,
had
sir.
said that from CVJ to C5
Yes,
was your
sir. So
localization, vertical localization.
The level at which this it is in CVJ to C5, that could be better explained by the presence of deltopectorals. That's what I feel. That's what I say.
You spoke of neck length. What is that?
Sir, the ratio between the neck length and the total height is there, sir. 1:14 is normal, sir. If it is skewed, then we can say the patient has a shorter neck, sir.
How do you measure? You've done that. You've written a measurement to it.
Yes, sir. So I had calculated, sir. I'm not very sure about the right method, sir.
Dr. Avinash?
Sir.
How do you measure the neck height?
Keep your video on, Dr. Avinash, I guess. Please continue.
Sir, from mastoid to the
mastoid
neck. Measurement. From mastoid to the clavicle, sir.
No, we are talking of the posterior aspect.
Yes, sir.
Anything to about cerebellar signs?
Oh, sir, cerebral signs were not present, sir. I forgot to mention that, sir. Yes. So usually, sir, I measured from the Indian, sir, to the C5, C6. This is the most prominent one, C7, but I'm not sure if it is right, so that's why I'll read up and tell you. No.
And neck, sorry, when we say neck body ratio or the neck total height ratio, it's 12.5 to 13.5. More than 13.5, you take it as, I mean, it is normal. Less than 12.5 is abnormal.
Yes, sir.
Short neck would be, neck is shorter.
Yes, sir. Compared to the whole body. Yes.
Sorry, so more than 13.5 will be abnormal.
Normal.
Right?
Yes, sir. More than 13 14. Yes,
0.5 will be abnormal. Right. So in this patient, did you mention the ratio?
So I've not mentioned, it's around 155 centimeter was his height, so around 10 centimeters, so around 15.
15.5, 1 is to 15.
Yes,
right.
yes.
So it is definitely short neck.
Definitely.
And did you also mention about the neck movements?
Sir, I've mentioned the neck movement, but I've not said that there was any restriction in that.
So they were normal.
So I've not mentioned.
Because
sir.
this was one of your prominent symptoms in
Yes, sir.
history that
Yes,
he had
sir.
restricted neck movements in all the directions.
Yes, sir.
Flexion, extension, lateral
So
flexion.
he was having difficulty in lateral movement bending, sir, which is present. And
No, but that has to come up in your examination findings, right?
Yes, sir. It should be written, sir. Yes, sir.
Because neck movements, if it is a prominent symptom, then it has to
Yes,
come
sir.
into examination also. It
Understood.
may or may not have a relevance with your final, diagnosis making.
Yes,
Neck
sir.
clicks you mentioned in the
Yeah,
history.
that I've mentioned.
In the examination, are there any clicks?
I've not mentioned that also, sir. Neck clicks I've not mentioned. It was there, sir. I've not
See,
mentioned
at least whatever is positive history, all of it has to be corroborated when you are examining the patient.
Yes, sir.
Right?
Yes.
Okay, so what is your etiological diagnosis?
Sir, I believe that it is it can be compression at CVJ level, sir. So mostly atlantoaxial dislocation can be present, sir. That is my first differential diagnosis.
Okay.
The second differential diagnosis can be lesions in the clivus, sir. Clival lesions which can be present or in the occiput. Then the other can be, sir, due to presence.
What lesions in this age?
Correct.
Sir, there can be presence of clival.
Clival
Dr.
chordoma.
Avinash, can you help him?
Clival chordoma, sir. Or a foramen magnum meningioma.
Younger.
Anterior or posterior?
Sir?
Anterior or posterior?
Anterior, sir. Anterior.
Okay, what else? So I will have a clicking sound then. If it's a tumor, why would I have a clicking sound? And then why sensory level till C5? Avinash and Vedant both can answer.
Sir?
So on examination, because we could identify sensory level to C5, that's what I had mentioned, sir. So it can.
No, but if this is a tumor
why
of
should
the
it have
fibers,
sensory
why
level?
should it have pain till C5? I
So
mean,
there can be
involvement till
presence
C5.
of syrinx which can be there, so that's more.
There is no dissociative sensory
Good.
loss.
In that case, it could be a PIVD C4, C5 with an upgoing
Yes,
syrinx
sir.
and
It
causing
can be, sir.
everything.
It can be a C2, C3, C3, C4 PIVD, which is having syrinx and causing all these particular symptoms, sir.
See, Dr. Vedang, you must understand that, even if you're putting a differential diagnosis, it has to largely corroborate with your history and examination complex. You have said all the cranial nerves are normal. There is nothing in the 7th, 8th, lower cranial nerves. And then you say that there is a lesion in the foramen magnum or the clivus. Dr. Avinash says it's anterior. It doesn't gel very well. How possible would you think that there is a lesion in the clivus oblique the foramen magnum, tumor, we are saying, which would produce clicks, which would not be associated with any cranial nerve palsies, no cerebellar signs, and would cause only symptoms which are related to the cord compression at cervicomedullary junction? A bit far-fetched, isn't it?
Yes, sir.
So, in fact, a much more probable diagnosis would be a traumatic disc at C2, C3, or say C3, C4, causing a upward settings.
Or a Klippel field itself can cause all these symptoms.
Correct. Just the bony ankylosis. Okay, Dr. Avinash.
Sir.
What do you understand by watershed in the cervical spine? Okay, it's related to the venous drainage of the spinal cord.
I'll ask you the other way around. That's why what Darpan is asking. As I asked Dr. Vedang about it, that did not mention about the hand weakness. So in high cord lesions, there is isolated lower motor neuron weakness of the hands. There is human weakness above and there is human weakness below. But the hands are weak in an LMN way. Why? Do you understand the question, Vedang and Avinash?
Yes, sir. It's because of the supply that C5, C6 regions, sir, that is probably easily compromised. That's why.
The compression at the level of CV junction. It's above C5, C6. There should be upper motor neuron weakness on the whole body below the level of compression. You have only mentioned that he is having difficulty in buttoning and unbuttoning. You need to see whether there is element weakness at the level of thenar and the hypothenar eminences.
Yes, sir.
So the veins drain the level of C5-6. As there is compression at the level of CV junction, the maximum venous congestion goes to the level of C6-7 radicals. So there the anterior roots gets involved because of the maximum venous congestion. As Darpan is saying, it's a watershed zone. So the level is draining at the level of 667, the venous congestion happens, and venous hyperemia causes ischemic necrosis of the radicals. So there is element involvement at the level of
hands.
So,
okay, Dr. Avinash, just last 1 or 2 questions. What is os odontoidium? Dr. Vedang?
Sir, in early age, sir, the fracture of the basal plate can cause a belly.
Basal plate.
Which plate?
Basal plate, sir.
Basal plate of?
The clivus region, sir, and the C1.
No. It's an unfused ossicle in relation with C2. Right?
Which is invariably confused as fracture of the
C2.
C2, which is actually not.
I suggest you also should read about the ossification centers of C2.
Yes,
it's slightly complex and very, very pertinent to this case. Could it be a fracture of the odontoid which caused all these symptoms? The patient had a fall.
Yes, sir.
He had a short neck, fair enough. Could it be a fracture of the odontoid causing all this?
Yes, sir.
Yes, sir.
See, when you particularly bring out the onset of symptoms after a trauma, all these things have to come higher up in your list of differentials. Right? Dr. Avinash, last question from my side, then Dr. Pinder may ask a 1 or 2. Are there any medical conditions which can cause this? Although may not be very particular at this age. Any medical conditions which can cause all this?
Your anterior horn cell degeneration or
really? No. Wait. No, now this is grossly wrong. Anterior horn cell degeneration. Dr. Vedang, which will be the prominent symptom?
Motor, sir.
No, that's okay. What? Will it be bulk? Will it be power? Will it be tone?
Bulk, sir, wasting of the...
Exactly. So is that the case with our patient? Our patient has predominantly spastic quadriparesis.
Yes, sir.
No, that's not something which will go very well with this thing.
TB, sir,
Anything
patient can
else?
have TB.
So Ayush has told rheumatoid arthritis. Yeah. Would you agree to this answer? Dr. Darpan has asked medical condition. Dr. Ayush Keshav Singhal has answered rheumatoid arthritis.
Do you agree?
Can present with similar complaints, sir, but will have other.
Can rheumatoid arthritis cause AAD?
Sir?
Can rheumatoid arthritis cause atlantoaxial dislocations?
Yes, sir.
Yes.
And upper CV junction normally is a very
So it's a
common.
much simpler, and much more common kind of illness, and it can cause. So,
what about CV junction tuberculosis?
That's a TB, sir, can happen, sir.
Is there any tumor which can cause bony destruction?
Bones, tumors are like GCTs and all can cause probably.
Aneurysmal bone cysts, GCTs can cause.
Sir, sorry to interrupt both of you. Can we shift
Yeah,
to
yeah,
the
let's
other
just-
candidate's
yes,
case?
next
Please.
seconds.
5 o'clock.
Sorry, Dr. Prashant, I think we are...
No,
Yes.
sir. It's enriching for all of us, sir.
The next case, Dr. Prashant.
Dr. Avinash, do you have your screen share ready?
One
Can you
second.
share your screen?
1 second, sir.
You are the co-host.
thank you, Dr. Vedang. Good case.
Thank you, sir. I'll read it better, sir.
Can you stay with me for the questions as well?
Yes, sir.
I'll ask many questions.
Now, Dr. Avinash will present the case and Dr. Vedang will try to answer the questions.
So we'll finish in half an hour this long case, right, Dr. Prashant?
Yes, yes, sir.
Okay.
Half an hour, 40 minutes would be fine because the OSCEs are relatively small. They are only spotters. So we can absolutely finish
Around
them in
40
20 minutes. It's not a problem. You can take 40, 45 minutes, no problem, sir.
Yeah, will not take more than that. Fine. Please, Dr. Vinash, continue.
Yeah. Sir, my patient is a 44-year...
Avinash, please put it in the slideshow mode. Yeah. Play.
1 second.
You can see.
Play. Yeah.
So my patient is a 44-year-old male who's a right-handed and a resident of a Pune, painter by occupation, and he is a self-informant and a reliable. So chief complaints of the patient is visual disturbances since 2 years, headache since 2 years, decreased libido since 1 year, and easy fatigability and lethargy since 1 year, and weight loss of 10 kgs in a span of 1 year, polyuria and polydipsia since 6 months. History of presenting illness, visual disturbances since 2 years, insidious in onset and gradually progressive, which worsened over the last 6 months and initially in the left eye, followed by the right eye. Gives a history of unable to see persons approaching from the side. Approaching from the side or objects in the periphery unless he turns his head to the side or the person or object comes to the front of him. On further questioning regarding the peripheral vision loss, patient gives a history of bumping into stools or missing steps initially that slowly progress to unable to see the fan or the roof of the room in the peripheral visions. There's no history of sudden visual loss or diplopia. There is no history of restriction of eye movements. There's no history of redness or watering of eyes, and there's no history of bulging of eyes. Headache, insidious and onset, which is gradually progressive in nature and duration of 2 years. Initially localized to left frontotemporal region and gradually progressed to the entire frontal region headache. And there is a mild to moderate in intensity, dull aching in nature, and on and off episodes. There's no diurnal or postal variations, and there is no aggravating factors. And headache is relieved by rest or analgesics. There's no history of nausea and vomiting, and no history of photophobia and phonophobia. Coming to the endocrine history, patient is married at the age of 17 years, who completed his family with 3 children at the age of third child is 12 years. Gives a history of significant decreased libido since 1 year. History of incomplete erections and early ejaculation since 1 year. History of loss of facial, body, armpit, and pubic hair progressively since 1 year, as patient observed decrease in frequency of need for grooming. History of easy fatigability and generalized weakness in 1 year, and stopped showing up for daily works in 6 months because of visual disturbances and increased fatigue and lethargy. History of unintentional weight loss of 10 kgs in 1 year, and patient gives a history of increased thirst, dryness of throat, and increased intake of water 3 to 4 liters per day in 6 months. History of increase in micturition 8 to 9 times in a day, but no history of urgency, hesitancy, incomplete evacuation since 6 months. There's no history of snoring, tingling or numbness in the hands, change in the shoe or the ring size. No history of excessive sweating, palpitation, swelling in the neck, anxiety, irritability, insomnia, no hoarseness of voice, or no history of diarrhea. There's no history of gynecomastia, no history of heat or cold intolerance, no history of easy bruisability, acne, change in facial features, or plain abdomen. There's no history of fevers, seizures, or loss of consciousness. Past history, there's no history of any comorbidities, not on any regular medications, no seizures, no trauma, no past surgical history, and personal history, diet mixed, sleep as adequate, and there is no addictions and no significant family history. To summarize, sir, a 45-year-old male patient with complaints of bilateral temporal visual field deficits, with history of headache, decrease in libido, loss of secondary sexual characteristics, easy fatigability and lethargy, polyuria and polydipsia, and significant weight loss. So can I tell my provisional diagnosis based on history, sir?
Wait, Dr. Vedang, anything else you want to ask?
Oh, no, sir. That's it. Thank you.
So you're clear about all your things?
Yes, sir.
Okay. So before we move on to the his differential diagnosis, what do you think? What are all the substrates involved in this? What part of?
Sir, most probably the lesion is in the sella, sir. Cellar lesion, or can be a sella supercellular lesion somewhere in the pituitary cavity, because the patient is hormonal involvement.
So why do you think that there is difficulty in looking at the roof? I mean, this particular history that he's having difficulty looking at the roof. So supposingly a person is not able to see at the roof, then what do you think this symptom can happen because of?
It can be ptosis, can be there, sir, or in that sense.
Ptosis, okay. What else?
Patient have both unable to see laterally in the peripheral region.
That you have told, that's fine. That's bitemporal field defect.
Yes,
but
sir.
you also mentioned about that patient has difficulty in looking at the roof.
In the peripheral vision, sir.
See, fine. So that is called as
superior quadrantenopia, I see.
Superior quadrantenopia.
Yes, sir.
So ideally, the superior quadrantenopia should come before the temporal hemianopia, right? When
Yes,
both
sir.
upper and lower field is getting involved, then only patient will have temporal hemianopia.
Yes, sir.
Initially, if there is compression from below, then patient will have a defect in the superior field, pi in the sky, right? And gradually, once both the fields are involved, then patient will have bitemporal hemianopia. Bitemporal hemianopia coming before superior quadrantenopia is not right. So one is that. Second, he can have a gaze palsy, which is not obviously in this case. Upward gaze palsy can cause all these symptoms, right?
Hypothyroidism can cause, if that is a thing.
Why hypothyroidism will cause these symptoms?
Hypothyroidism can cause difficulty, extraocular muscle weaknesses, or sometimes that is a reason.
But that will be in all directions, right? Okay. Headache. So why do you think headache came after visual field effects? Okay, what kind of headache is there in cellular lesions?
Sir, could be either increased raised ICP or dural stretch.
Raised ICP headache in cellular lesion will come when the tumor will reach till the floor of third ventricle.
Yes, sir. Or stretching. Dural stretching pain, sir.
Which dura?
Tuberculum cell. Tuberculum cell dura, sir.
Diaphragma cell.
Diaphragma cell.
Right. So what is the nerve supply of the diaphragma cell?
Sir, trigeminal nerve, ophthalmic division.
Trigeminal nerve. So where is the pain?
Sir?
If there is compression over the diaphragma cell because of a cellular lesion, then so there's from dorsum cellular dural layer stretching, right? So what kind of pain? Where is the pain radiated to?
Sir, in the bifrontal region and forehead and retroorbital region.
So it is mainly in the bregma, right? The predominant pain is in the bregma. So as this is a very classical, like in collar stud abscess, you see that once there is pain, and once it invades diaphragma cell, the pain goes away. It comes into the open brain now. Understood that? Once it becomes invasive. Okay. So your first symptom is because of the involvement of the
dura.
No. So see, for a cellular lesion to cause compression over the optic apparatus, it has to compress the diaphragma cell dura first, and then the cellular extension will cause visual field effects.
Yes, sir.
But in your, it is the opposite. The headache came after the visual field deficits.
Yes, sir.
How do you explain that?
Sir, as in like the visual complaints and headache are since 2 years. And
Together, you mean?
Yes, sir.
Can it be a supracellular lesion which has caused dural compression later on?
Sir,
But Sagar has answered it can be an infundibular lesion. Do you agree to that point?
Yes, sir.
What do you mean by infundibular lesion?
Sir, a craniopharyngioma.
Okay. So in
Or
craniopharyngiomas, what kind of defect patient will have? Visual field deficit.
Patient can have a bitemporal hemianopia in which the inferior fields are involved first and superior temporal fields are involved in the later date. I mean, delayed, sir, compared to the inferior visual fields.
Okay. So then again, the question comes that if there is a supracellular compression, which is compressing the optic nerve from optic operators
Chiasm
from
from the
there'll
superior.
be pie in the floor.
Yes, sir.
You have difficulty looking down, going downstairs, eating food, right? And then the bitemporal field defects. But if it is compression from below, the superior fields go before. So pie in the sky comes, right? Okay. So a 45-year-old male with pituitary adenoma vis-a-vis 45-year-old male with craniopharyngioma. Do you
Yes, sir.
think the symptoms will be same or different apart from visual field deficits and headache?
A patient of 45-year-old with a craniopharyngioma.
Can have a craniopharyngioma?
Yes, sir.
Which is the usual age of presentation of craniopharyngioma?
Sir, craniopharyngioma have a bimodal distribution in pediatric
What is the
and
adult में किस age में होता है?
sir, for 35 to 50, 65, sir.
Vedant, do you agree to his answer?
So 50s, 60s में होता है, sir.
Later it goes into the later on. Okay. So Vedant, the next question comes: decreased libido and loss of secondary sexual characters. What do you think this symptom is because of?
Sir,
Let out Vedant answer because then we'll come to you, Dr. Avinash.
yes, sir.
This is his time to answer.
So it can happen due to the involvement of the pituitary, sir. The hormone cycle can be disrupted, sir. That's the reason.
Testosterone, you mean?
Yes.
Okay. So basically hypogonadism, right? Okay. Easy fatigability and lethargy?
That can be due to the thyroid involvement, sir.
But in thyroid, the patient should have, you mean hypothyroidism?
Yes, sir.
And why there is weight loss? How do you explain weight loss? So there's one answer, Dr. Harshvardhan Haldipur from hypocortisolism.
That will also not cause weight loss, sir.
That is also not cause weight loss. So in weight loss, you did not mention about loss of appetite as well, Dr. Avinash, that you should have mentioned.
Sir, unintentional weight loss and there's no history of loss of appetite, sir.
So weight loss happens in which type of hormone abnormality?
Hyperthyroidism can cause.
Hyperthyroidism can cause. Can it be a TSHoma causing other symptoms? Can it be a TSHoma? If this would have been a TSHoma, supposedly, so what other complaints you would have asked for? Hyperthyroidism, you mean, right?
Sir, is agitation, irritation, or in all those symptoms, sir?
So patient will have tachycardia, palpitations, increased appetite and weight loss. Patient will have weight loss in spite of increased appetite. Patient will have tremors, fine tremors. And patient will have perspiration. Okay. Polyuria and polydipsia. Why do you think there's polyuria and polydipsia? Dr. Vedant, it is your time to answer.
Sir, again, sir, because of the involvement of there can be involvement of the pituitary and the hypothalamic region also can be involved, sir. That situation can cause the stalk can be involved.
So in what percentage of pituitary lesions you find preoperative diabetes insipidus?
Less, sir. Less. It is more common in craniopharyngioma.
What percentage of craniopharyngioma present with preoperative diabetes? I'm not talking about post-op. It's 8 to 30% in craniopharyngioma and less than 2% of the pituitary adenomas. Okay, usually it doesn't cause. Okay, supposingly there is a lesion in the sella, right? And then there is a lesion in the pineal.
I'm sorry, sir. I lost some connection in between.
Sir, you are muted.
Not muted, I think. Yeah, okay.
Now it is okay.
Yeah. So which is a cardinal feature, in which lesions, in which tumor? The preoperative DI is a cardinal feature. Which type of tumors? I've asked you already, but still. So somebody has answered already, germ cell tumors. So there is a germinoma. So there is the preoperative DI is the rule. Usually this is not the age for this, is the younger patients, and they have a concomitant lesion in the sella as well as in the pineal gland. Okay, sure. So, Vedant, so what's your diagnosis? You go with the differential, please, Dr. Vinash.
Sir, my provisional diagnosis based upon the history is a cellar and a supracellar space occupying lesion with a hypothalamo-pituitary axis involvement and with compression on the chiasm. Sir, my first differential diagnosis pituitary macroadenoma and
functional or non-functional?
Sir, functional pituitary macroadenoma.
Which functional pituitary adenoma?
There are multiple hormones that are, I would, based upon the history, I would think there are multiple hormonal level, I mean, multiple hormones are involved in it, sir.
No,
Wait, there's a cardinal confusion here now.
Yes.
Please, Dr. Vedant, can you define functional pituitary tumor?
Yes, sir. It will be particularly a single cell which will be causing. So there will be a singular hormonal issue. When there is multi-hormonal involvement.
No. Wait. Again, the definition is incomplete. When we say single hormonal issue,
what do you mean by that?
So we use for, issue is not the thing. Issue, so we call children also as issues. What is the issue? Excess or deficiency?
Excess.
Yes. So, Dr. Avinash, now you find what is wrong with your answer?
Yes, sir.
The deficiencies are caused because of the compression of the non-pituitary gland.
Yes, sir.
You call it a functional tumor if there is a particular
hypersecretion.
1 or 2. Yes.
Yes, sir.
So now you tell us whether it is a functional or non-functional.
Sir, non-functional pituitary macroadenoma.
Can any functional pituitary macroadenomas look like non-functional pituitary adenomas, which are usually missed in routine monitoring of the hormones? And as Dr. Vedant has also answered, but one thing, the functional pituitary adenoma usually, it's not necessary that they have only one hormonal hypersecretions. There can be pluri-hormonals as well. Somatomammotrops are there, then can be GH as well as corticotropic secreting hormones. Then, okay, that is one. Secondly, what we call is that a non-functional pituitary adenoma. Sometimes there is hypersecretion of certain hormones which are usually not picked up in routine investigation. What are those? Gonadotropinomas. We don't usually screen them for gonadotropinomas, right? Okay, sure. Okay. So one is your pituitary macroadenoma. This is why cranio you were saying? Why cranio?
Sir, based upon the history of his visual field deficits, his first visual...
Your classical visual field deficit is from a cellular perspective, not from a supracellular perspective. Do you think pure cellular craniopharyngiomas exist?
No, sir.
No, they do exist. Man. There are pure cellular craniopharyngiomas. Okay. So what kind of craniopharyngiomas are seen in adult life?
Papillary, sir.
Okay. So how do they look like on radiology? Different from pediatric ones?
Sir, pediatric adamantinomatous craniopharyngiomas.
It's a histological diagnosis, no? I'm talking about radiology.
हाँ sir. Adenomatous pediatric cases are of cystic inconsistency, sir, whereas papillary is of solid in consistency. So there is a
anything more cardinal feature?
Presence of
Apart from that,
calcifications.
Calcification is more commonly seen in pediatric age groups, right? Which is better? Which has got a better prognosis? The adult one or the pediatric one? The adult one has a better prognosis, right? Why meningioma? Which meningioma are you talking about?
Sir, suprasellar.
Like, but Vedant, do you agree to this sequence of diagnosis?
Tuberculum cellular meningioma and all can cause, but the compression is coming from down. So
do you think that tuberculum cellular meningioma usually cause all these hypothalamic?
It has to be very big to cause the hypo hormone also.
Okay. And usually they go, if such a big lesion, they usually go along one optic nerve to the optic foramen. They cause more, visual loss as compared to root unless it is very big. What vascular lesion are you talking about?
Sir, hematoma.
Hematoma like? Hematoma in which region?
Hypothalamic.
Hypothalamic hematomas. Do you think this is the age for hypothalamic hematoma? And what is the classical feature of hypothalamic hematoma?
Adolescents mostly in gelastic seizures or
gelastic seizures and precocious puberties and all that. Anything else? Any other vascular lesion you can think of? Yeah, that's right. Gelastic seizure is there in the answer.
Maybe undiagnosed aneurysms are large one which can be there.
Less likely, right? Aneurysms arising
That's why it's the end of the
aneurysm rising from the cavernous ICAs causing compression over the optic, but it will have some features of the cavernous sinus involvement as well because there is sixth nerve, third, fourth, fifth along with it.
Yes, sir. Multiple cranial nerve involvement probably.
Usually don't feel like. Any other diagnosis you can think of apart from this? And these are the diagnoses only. So these are your 4 differential diagnoses, right? Darpan, you would like to. So there's another diagnosis come. Are you able to read the down chat also? Rathke's cleft cyst. Do you think Rathke's cleft cyst can be there?
Yes, sir.
Okay. Okay. Darpan, any questions you want to ask till now?
Dr. Avinash, one important thing, because you said vascular lesions, now this takes us back. You did mention about vision, but you only spoke about, primarily about field of vision. You did not mention diplopia.
Sir,
you mentioned diplopia.
There's no history of diplopia, sir.
Okay. Why is it important? If you have vascular lesions, unless cavernous, it is rare to have
involvement to the cavernous sinus lesions, which could compress
the extraocular muscle palsy.
Yes, sir. Involvement to the oculomotor or the yes, sir.
And it is most likely to be unilateral, so that with the binocular vision they will have diplopia. Yes, Dr. Vedant, he said sudden loss of vision, no history. In which cases do you feel they can have a sudden loss of vision?
Pituitary apoplexy can be there, sir.
That is one.
Pituitary apoplexy.
Anything else which can cause loss of vision? May not be that sudden, but fairly. I mean, it is going down at a particular pace, and then suddenly you find that patient has developed too much of deterioration of vision or develops diplopia. Acuity goes down, blurring happens. Dr. Avinash, apart from apoplexy, another thing which can cause slightly hastened loss of vision. Dr. Binder mentioned also a while back. If it reaches dash, it will cause
intracranial
hydrocephalus.
Hydrocephalus.
IH is not the answer.
ICP
What
basically.
is mentioned. I think it's hydrocephalus, right?
It's hydrocephalus, right?
Hydrocephalus causes slow vision loss. And if at all the vision loss happens in hydrocephalus, it is usually permanent. It's irreversible. Okay. So what is the definition of hypoplexy? Is it the bleed only? So it is a sudden enlargement of a tumor because of bleed, infarction, or a cystic degeneration. So apoplexy means sudden enlargement. Okay. So let's
Next.
I think we're running short of time. Yeah, complete your physical examination fast.
General physical examination, sir. Conscious, a patient is conscious, alert, and cooperative. There no signs of pallor, icterus, or cyanosis, clubbing, or lymphadenopathy. There's a spasmus of hair on face, body, axial, and pubic region, sir. And there's no signs of frontal bossing or prognathism, macroglassia, buffalo hump, or purple striae over the abdomen. No neck swellings or nipple discharges are present, sir. Higher mental functions are normal, sir. Cranial nerve.
For a male, I would have asked more about gynecomastia than nipple discharge, which is, yeah.
Sir?
For a male, gynecomastia would have been more important as compared to nipple discharge if you're talking about prolactin
Yes, sir.
or a hypogonadism. Yeah.
Cranial nerve 1, normal olfaction is normal bilaterally, sir. In cranial nerve 2, so pupils are 2 and equally reactive in direct and indirect reflexes, sir. Visual acuity using the Snellen's chart is 6 by 6 in bilateral eyes, sir. And visual field deficits by confrontation test, there is a temporal hemianopia in right and left eye, sir. Color vision using Ishara charts, the right and left eye intact color vision is there, so normal. Fundus using a direct ophthalmoscope in right and left both eyes. The discus
normal.
normal.
Right?
No, sir.
Okay.
Sir, all of the cranial nerves, 3 and 4, 6 extraocular movements are full. There's no nystagmus. Pupils are direct and equal and reactive. Consensual reflexes are reactive. There's no ptosis. The cranial nerve 5 facial sensations are intact. Muscles of mastication are normal. Corneal reflex.
All cranial nerves are normal, right?
Normal, sir. Yes, sir.
Go next.
So motor system and sensory systems are intact. So power 5 by 5 in all 4 limbs. Tone is normal. Pain, touch, and temperature, joint proprioception and vibrations are normal, sir. Reflexes, all dependent reflexes are present, and plantar is mute bilaterally. Cerebellar examination, there is no abnormalities, sir. Systemic examination, CVS S1 S2 clear, normal, and R is clear. Abdomen soft and non-tender, sir. Normal. Digital examination is normal. By provisional diagnosis after examination, a cellular and a supracellular space occupying lesion with my first working diagnosis of pituitary macroadenoma or craniopharyngioma.
Okay, do you agree to his diagnosis, Dr. Vedant?
Yes, sir.
Okay, so I would like to investigate this patient.
So I'll start with the hormone investigations, complete hormone workup, then so all growth hormone, thyroid profile, prolactins.
So do you think growth hormone is important or something else?
IGF-1, sir.
Why IGF-1 is more important? Which is more important, growth hormone or IGF-1?
IGF-1 is more important.
Why so?
So post-surgery, the change can be monitored faster compared to growth hormone because it takes time to...
Not at all. Not at all. See, we always measure growth hormone levels and IGF-1. So if we say that IGF-1 levels are more reliable as compared to growth hormone, why? And to your answer that growth hormone is more easily measurable post-operatively. IGF take 12 weeks to come down. Okay, not the growth hormone. Growth hormone comes down earlier as well. So how do you say that? So growth hormone comes in pulsatile manner. It is not constant throughout the day. So the liability index of growth hormone is less. Supposingly, it's a growth hormone secreting adenoma. So they think that the GH is 10, it is enough. But further investigation would like to do to confirm that it is a growth hormone secreting tumor. Apart from IGF-1.
Provocative test of inducing hypoglycemia causes
hypoglycemia. This is an answer you can see from Dr. Sagar. OGTT, na? Oral glucose tolerance test.
Glucose tolerance test.
What does that do?
So creating the hyperglycemia, oral glucose tolerance, you ingest with patient with glucose agents, causing a hyperglycemia, which eventually suppresses the growth hormone production, sir. But if there is a excessive growth hormone production, or as in like growth hormone secreting pituitary macroadenomas, then the growth hormone levels are not suppressed with OGT testing, sir.
What levels? Supposedly pre-OGTT is 10.
10.
Post-OGTT is 8 or 6 or 5 or 4. Is it acromegaly? Is there a cutoff? इसके नीचे हो नहीं जाना चाहिए, इसके नीचे चला गया तो स्ट्रेस हो गया, नॉर्मल हो गया.
So less than 2.
But Vedant?
No, sir.
So less than 1 we have to achieve. Okay, one thing. Secondly, for a group, see, we have to treat as a pituitary adenoma, right? I think 5 minutes more are there. Okay. So if supposedly for acromegaly you have operated the patient, so how do you say for a biochemical cure? What are the levels to be achieved? See, there is 2 things. One is disease control. One is biochemical control. Cure. Somebody has answered already that it should reduce to less than 1. Or post-OGTT less than 0.4. And IGF levels are measured ideally at 12 weeks.
Okay, sir.
Okay. Darpan, any questions you would like to ask? You are muted. Darpan.
Darpan, sir, you are mute. Kindly unmute you.
Dr. Vedang,
So,
in this patient, are there any features to suggest acromegaly? History-wise
sir.
or examination-wise?
No, sir.
Right. So, do you feel it will be more prudent to do the hormone levels first, or to achieve at a diagnosis via radiological investigation? Why should you start, doing hormonal investigations to begin with?
So, I mean, usually, sir, I mean, we usually want to rule out prolactinoma, though it's not given by history here only. But in case there is prolactinoma, then we medically.
How do you define prolactinomas?
So it's dependent upon the prolactin level, sir. More than
100 levels. 100 microgram per deciliter is the prolactin level.
Yes, sir.
130 level is the prolactin level. Pituitary macroadenoma is there. Vision loss.
You call it a prolactinoma?
You call it
Or
a
you like to
prolactinoma?
confirm?
No, sir. It can still be a stock effect. It has to be more than 200.
Right.
Not much. No, sir, I didn't mean to say that we can only do hormone first.
So you'll have to measure it by the volume of the tumor. Right? Up to 250, yes, of course, for a large tumor, it can be a stroke effect.
Yes, sir.
Okay, and okay, if supposedly it's so supposedly it is 400, the level of prolactin is 400. Now, what do you do?
So you can give medical treatment first, sir, try cabergoline.
No, to confirm the diagnosis. There's still something remaining.
So you do the prolactin levels using dilution to check if the.
So what dilution? What does dilution do to the levels? So why do you want to do dilution?
So there can
why
be.
do you want to dilute?
Clumping of the prolactin is there, so that's why the values come range sometimes.
And secondly, supposedly the actual value is 2000. The hook effect is there, yes. So you have started cabergoline, right? And the second level comes up to be 800. You said that cabergoline has not acted. The actual values were 2000. It is coming down, right? Understood what I'm saying? Okay, that is one point. If supposing the patient is grossly hypothyroid,
what all would you like to correct pre-surgery, and what all you can leave it for post-surgery? And it is very pertinent to this patient. Hint.
Yeah, patient has got symptoms of panhypopituitarism. Yes.
Correcting the hypocortisolemia, sir.
And
Thyroid.
So
correct.
the question comes you exactly. That patient has come to you in an unconscious state. You think that the patient is either hypothyroid or hypocortisolic or both. You don't have the values, which you will correct first. Thyroid or the cortisol, or both.
Cortisol, sir.
Why so? Why not thyroid? You not get thyroid? Then what is the fundamental basis behind it? See, if you will give thyroxine first, it will further metabolize the remaining cortisol in the body. Patient will go into further hypocortisolism and will go into insulin crisis.
Yes, sir.
Okay, supposingly there is no immediate visual threatening or danger to the vision,
Yes.
right? There is no immediate emergency. Patient is grossly hypothyroid. Till what time you want to wait to correct the thyroid levels? I mean, you have started thyroxine from today.
Yes, sir.
So what do you think that the levels will be achieved in how many days?
3
or
to 4
weeks
weeks.
or months?
3 to 4 weeks, sir.
2 to 3 weeks. It is at least that levels. And what is the ideal measure? Which value? T3, T4, TSH. What?
TSH.
TSH.
No.
T4, sir.
Further improvise.
Free T3, T4.
Free T4. Most important than free T3.
Hmm.
Dr. Vedang, if
Sir.
it is hypothyroidism because of pituitary adenoma, what values of T3, T4, TSH do you expect? Which will be low, which will be high?
Hypothyroidism because of pituitary.
Pituitary adenoma. That is
Primary
what we are discussing,
hypothyroidism
right?
and
A
secondary
cranio
hypothyroidism.
oblique pituitary adenoma compressing the regular normal pituitary and causing hypothyroidism. You do a thyroid profile on this patient. What are your likely findings? Just tell us what is increased, what is decreased.
So TSH will increase, T3, T4 will be low.
Dr. Avinash?
So decreasing the T4 values and increasing of the TSH levels, sir.
No.
Increased TSH levels.
Sorry, both of you are mistaken. We are talking of central hypothyroidism. The hypothyroidism, I mean the T3, T4 levels are going down because there is no TSH, which is produced by the pituitary. So all three will be low.
Yes.
See, in
It
a
is
primary
peripheral
hypothyroidism,
hypothyroidism in which TSH will go up if the T3 and T4 are low. Because T3 and T4, for example, if it is low because of an iodine deficiency or say a thyroid cancer, the TSH will rise in order to stimulate the thyroid more. But when we are talking of central hypothyroidism,
Centrally,
all three will be low. This is very important for you to understand.
similarly in thyroid secreting tumors also, TSH and T4 both will be high. But in Graves' disease, because of the thyroid, T4 will be high, but TSH will be
very low.
Yeah, that's how it is. Same goes for Cushing as well. You know? Yeah.
What else apart from the hormonal profile and the imaging? Anything else which you would like to do preoperatively?
Sir, ophthalmological examination, sir.
Which includes?
Perimetry and fundus examination.
And
the visual acuity.
Correct.
Okay, so supposingly patient doesn't have visual field deficits. Is there any other test which we usually do these days to diagnose subtle or early signs of visual apparatus compression, which is quite common? So somebody's again answer RNFL. What is that? So retinal nerve fiber layer thickness we do by the OCT, optic coherence tomography. With the ganglionic cell layer thickness and the retinal fiber layer thickness we check in for. Supposingly patient doesn't have a deficit in the vision, you think that there is optic nerve compression, you still want to further subjectify or objectify, I mean, you go in for OCTs these days. That helps in diagnosis. Okay, I think we wrote that one.
I think we can close.
Thank you, sir.
Thank you. Dr. Prashant,
Prashant?
Yes, I'll share my OSCE, sir. Thank you so much. Okay, you can show your radiology. We have time, 5 minutes, sir. Are these the
Okay.
only slides, Avinash?
Sir.
Okay. Whatever sir asks.
So what's your diagnosis in this? Please go to the MRI first and then CT. I mean, other way around is also okay. So what's your diagnosis?
So there is a hyperintensity. This is a T1 weighted image, sir. Axial and the sagittal sections. And there is a hyperintense lesion in the T1 image, sir.
What do you think? Why it is hyperintense? What are the structures of the hyperintense on T1 weighted images? One image is good enough to tell a lot of things. Hyperintense on T1, but dung.
Pituitary.
Fat
Pituitary will be hyperintense on T1.
Fat can be the hyperintense.
You think this is lipoma?
Cholesterol, sir.
Cholesterol will cause. Anything else?
Cholesterol.
Yes, iPhone 4 has raised hand. Please answer. Yeah, true. So there can be apoplexy, bleed. You have seen different stages of the blood, acute, hyperacute, and the chronic.
Yes, sir.
It can be blood, it can be high melanin content, it can be very high protein content, as well as the fat. So out of all, why you say it's a pituitary adenoma?
Not see pituitary separately, sir.
Can you see pituitary separately?
No, sir.
Okay. So you think it's pituitary apoplexy? Or a cystic pituitary adenoma with high protein content? Go to the next scan.
So this is a T2 image, axial cuts and GRE image of axial cuts.
Can you see some blooming in the GRE images?
Yes, sir. There is a peripheral blooming of.
So what structures bloom in GRE?
Calcification, sir.
And?
Blood, sir.
Okay. So blood and
calcification
both bloom. So what other images sequence you can do? Or a CT can will also suffice.
Yes, sir. CT or an SWI image.
SWI images will be good. Okay. Go to the next slide.
So this is a contrast enhanced images showing there is a thin rim of peripheral contrast enhancement is there, sir.
I think we could have zoomed in the images close to the pituitary so that we could see whether there's some pituitary separately seen or not, because I could see some pituitary.
Yeah, yes, sir. T1 weighted image also, there is a small pituitary compressing that.
In T1, how does a posterior pituitary look like?
Bright.
Why so?
Bright spot.
Why so? Again, high fat and melanin content, right? So even if it's hypo, the lesion is hypo and there'll be separate pituitary. Go to the CT scan now. CT scan, please.
Yes, sir.
Okay, so what do you see in CT scan?
Sir, there's a plane and contrast enhanced images, sir.
So you can see calcification around it?
Yes, sir.
So what do you think the diagnosis is now?
Sir, craniopharyngioma.
Okay, so can you see calcification in pituitary as well?
Yes, sir.
How many percentage of cases? Less than 5%. See, there are 2-3 things which is there. Sella is not widened. There is no sellar bulge. It is predominantly cystic. Patient has plurihormonal deficiencies. And of course, there is some peripheral limb of calcification. So the craniopharyngioma goes above the pituitary adenoma, right? So peripheral calcification, of course. So cranio would be a preferable diagnosis in this as compared to pituitary adenoma.
Yes.
So I'll share my screen now, sir.
Okay.
And then Harsh will share his screen. I have two OSCEs, one for each or to one candidate, one of the OSCEs, whichever way you want to. Can you see my screen, sir?
No, Dr. Prashant, we can see.
I'll do it again. I think I'll ask Harsh to share his screen. Harsh, can you share your screen first? So, can you tell the diagnosis?
So, T2 weighted coronal and axial images, sir. I can.
What you can see, first explain what you can see in the radiology.
Yeah, exactly. Yeah, now what you can see, Dr. Avinash?
So, dumbbell shaped swelling with a hyperintense and hypointense lesion involving the right temporal region, sir.
Only in the temporal region?
Temporal and the posterior cranial fossa region also. Temporal cranial and temporal and occipital. And fifth nerve is not visible separately, sir. Over here in the right side.
Okay, so the next question is, what extra neuronal marker on MRI differentiate with other differential diagnosis? You can see the contrast images now.
Yes, sir.
Apinder sir, you can go ahead with whatever questions apart from this if you want to ask.
Yeah, it's okay, fine. I mean, it's okay. So what do you think? What are the differentials you think that the lesion which is going in the middle crescent fossa as well as the posterior cranial fossa? A lot of people have answered already the question, but still.
Schwannomas or trigeminal schwannomas or
Okay.
the lower cranial of schwannomas.
Other lesion, lower cranial of schwannoma. Why would a lower cranial
Lower cranial would go to middle cranial fossa.
Okay, so what other lesion go from the lower cranial fossa? I mean, from the posterior cranial fossa to the middle cranial fossa, apart from trigeminal schwannomas.
It's the other way around, I think now. I think GBMs can be 1.5, 2 centimeters or 1 centimeter because we know 90% lapses are there. But now
Harsh, your audio is on.
Different, which is only guideline. Then in IDH and Astros, as the
Harsh is sitting in a conference on gliomas.
majority will be on the IDH inhibitors now. Whether it will change
the GBM, somebody's answering.
Yeah.
GBM.
Whether they put a lid on the
No, it's not GBM. So, Dr. Vedant, what I mean to say is
a CP angle tumor can be going in from.
What other lesion? What? Sorry.
A CP angle lesion or epidermoid cyst that can.
Epidermoid, but what is the most common differential of a fifth nerve schwannoma? Trigeminal schwannoma.
Meningioma.
Which meningioma?
So the sheath of
The vestibular schwannoma is the wrong answer. Somebody has iPhone 4 has answered. I think it's not wrong. Yeah, this is right. Petroclival meningiomas. Petroclival meningiomas also, though it is very typical of fifth nerve schwannoma, but petroclival meningiomas also go from the posterior fossa to the middle cranial fossa. So one thing is dural base. What else? What is the cardinal feature? Any other radiology you would like to
contrast
see?
enhancing homogeneously
It will also
contribute.
enhance beautifully, and there will be homogeneously enhancing. Cystic component will be less. Anything else? Supposingly the schwannoma is also beautifully enhancing, which usually they do. It's not necessary that they'll have a cystic degeneration, right? So then anything else which you can do? What about the bone?
Sir, there'll be bony involvement also in meningiomas.
What involvement, sort of?
Can be increase in the bony cell hyperostosis.
And what about schwannoma?
Destruction will be there, sir.
What is that word called? What is the typical word called? So basically there is a sharp cutoff in the petrous tip that's called as truncation of the petrous. So if you see on the CT, so there will be sharp cutoff in fifth-nerve schwannoma, it's called truncation of the petrous. So the question is classification. The other is nerves most likely. What approach do you choose in this case? See, then you will be able to answer the question number 4. Nerves most likely to get damaged apart from the fifth nerve during surgery.
Middle cranial can be taken.
From the CP angle, you want to go to the middle cranial fossa, or from the middle cranial fossa, you want to come to the CP angle?
Because the major bulk is in middle cranial fossa.
Middle cranial fossa to.
Supposingly the bulk is equal.
So we can go through a CP angle first if there is patient is having hydrocephalus or other symptoms. So
what is the disadvantage of CP angle approach in fifth nerve schwannoma? I mean, in this kind of anterior based lesions, right? Have you assisted vestibular schwannoma surgery?
Yes, sir.
So what is the relation of the 7th-8th nerve complex to the tumor usually?
Seventh nerve comes.
They are behind the tumor, right? The tumor comes first. If you go from a CP angle approach for this lesion, I mean, even if the middle cranial fossa lesion is smaller, the nerves will come before.
Seventh nerve will come
for an anterior petrous lesion, for a petroclavial lesion, for a fifth nerve schwannoma. See, the nerves are before it. So, okay, you're going from a Kawasai's approach, supposedly. Kawasai approach means, what do you mean by Kawasai approach?
Middle cranial fossa subtemporal.
Means, yeah, somebody has mentioned already. Petrosectomy. Okay, intradural or extradural?
Extradural.
Okay, so what nerves comes in the way? What is a Kawasai's triangle? Is it a triangle first of all? Okay, it's okay. Anyone? Nash? So you see the V3 nerve, you see the GSPN,
yes,
you see the arcuate eminence, and you see the sinus. That's a quadrangle, right? There you go. So once you try to drill the anterior petrous, which is not required in this case, it has already been destroyed by the tumor. It is already widened. It will take you down. Otherwise, if it is not destroyed, you need to do the interior petrosectomy. You can now injure the GSPN and then the 7th nerve complex as well, because it is the internal artery meatus is there only if you see that. ठीक है, I guess.
Next slide, Harsh. Harsh. Yeah. Play the video, please.
What do you see in the CT?
Subarachnoid hemorrhage in the left involving the Sylvian fissure, left Sylvian fissure.
Only left?
Only left.
And a bilateral, left and right, yes, sir.
Okay, then. This is a CT angio. What are your findings and what is your plan? She's already pointing to it.
Sir, left MCA aneurysm is there, sir.
MC means what? MC is huge.
Where?
M2 segments.
Where in MCA?
MCA bifurcation.
So can you show us the Harsh, can you just scroll the image where there's bifurcation?
Okay. Actually, I think there is a DSA, there is a CT angio construction. Yeah. Yeah. So the questions are on your screen. See and answer, Dr. Avinash. You know what these terms are?
Sir,
See,
If you don't know, ask him.
these two terms are pointing towards two different modes of treatment.
Sir,
And then the results.
Sir, BRAT long-term results indicated that coiling clipping is more pertaining method compared to coiling, sir.
In view of
long-term long-term outcome, sir.
In view of clinical outcome, you mean?
Yeah, that is ISWA. Sorry, it's not ISAT. That is ISWA and BRAT long-term outcomes in terms of MC aneurysms.
Yeah, ISUI is an unruptured one, no?
Yeah, yes.
Is
ISWA and BRAT only for MC aneurysms. What is the long-term outcome? That is the question. Second thing is, how many aneurysms do you see here actually?
Yeah, that's what the next question I wanted to ask, the same one.
Yeah, because that opens a lot of questions after that. I mean, I don't think you can get a better VRT than this.
Yeah.
Two aneurysms are visible over here, sir.
Yeah. So the question is, while doing, what will you plan for this case?
It's okay. If
That's
you don't
not
know.
difficult. I mean, it's a straightforward.
Yeah, go ahead. If you don't know, you can just say, I don't know.
Yeah,
Let's go
Dr.
ahead.
Vedang, you can chip in if you know the answers.
So you can go for a craniotomy and clipping, sir.
Okay, so which one will you clip first?
So the bifurcation only, because that's the larger one.
Why? But then the question arises, if you clip this first, won't the clip obstruct the smaller aneurysm clipping?
See,
Clip will come in the way, right?
Yeah, which aneurysm? Talking about Harsh is talking about Dr. Vedant.
That's
This is which artery? What is the first branch of MCA which comes out?
It's in the M1, sir. That is.
The aneurysm has to happen on a branching point, no? It is.
Yes, sir.
See, though there are some dorsal IC aneurysms which are not on the branching point, but still it is in the branching point. Which branch? Which artery is rising? That Dr. Harsh is asking.
It's a very simple. The first branch of MCA.
First branch of MCA. Yeah, exactly.
I'm not able
You must
to.
have seen plethora of these cases.
Yeah.
So it's not lenticular stride, doc. So that is
Not
wrong.
that obviously.
Someone has answered right, but others are answering lenticular stride. It is wrong answer.
See, in the short form, somebody has answered. Just expand the short form at least.
Yes. You can scroll on, Dr. Vedant, no issues. Yeah.
Antitemporal.
Yeah. So what do you clip first? That is the question. That is the conundrum in this case. Otherwise, it's just a run-of-the-mill case. The question why it has been added here is, what do you clip first? In the context of the hemorrhage that has happened, what do you clip first? This is the hemorrhage that the patient has presented with. She had a hemiplegia of 2/5. Now you opened the case, the brain is bulging on you. Obviously, the brain will bulge as soon as you open in this. So what do you do first? Do you go after the unruptured smaller aneurysm? I'm giving you a lot of clues here. Or do you go after the ruptured?
Ruptured one first and clip it, and then probably wait and then go again.
Or you want to go in again after some
Again.
time, although you
Because-
have exposed this aneurysm in the same sitting.
Because we said the brain is bulging and there is hematoma, so
No, but anyways, we have to expose the MCA, right, for the temporary control.
Obviously,
Yeah.
how will you get proximal control for the ruptured aneurysm unless you expose this?
And for temporary
The
control,
whole
obviously, we
crux
should
of
have
any
the.
aneurysm surgery is to get proximal control, right? If you've got proximal
sir.
control, means you've got this.
Doc, whosoever answered hyperventilation, Dr. Harshit Garg, we do not hyperventilate usually in aneurysm because it causes further vascular geopardy.
Absolutely.
Right? And it causes vasoconstriction, and usually avoid unless there is no other option. Like opening cisterns and opening up CSF, I think is the best method to,
Is question 4? Can you answer question 4? Apart from nimotropin, which we all give, any other adjuncts you know for vasospasm treatment?
Yeah.
Milodin.
Milrinone is fine. Next, what else?
Next.
Are there some statins which you give?
Yeah.
So
Vedant, come on, man. These you must be dealing like every day.
So we're not giving any statins yet, sir.
I was expecting shaking of the head and lumbar puncture at least. All these things you stuck at statin only as of now. There's a paper from your institute only. One of your professors, a very good friend of mine, has authored it. If he comes to know you're unable to answer this, then
I'll go through that, sir. Go through that.
People have used, statins and even sildenafil.
Doesn't reflect well that you don't read your own institute's papers.
That's it.
Dr. Vedang, what is the take on intra-arterial rather than systemic this thing, milrinone oblique nimodipine?
We do give
Is intra-arterial better or
Yes.
a systemic thing is better?
Intra-arterial.
So we're giving intra-arterial, so.
Any disadvantages to that? I mean, there was a time when it was too much in vogue, and then it went into disrepute, or we're not preferring it very much nowadays. Any reason why intra-arterial? What is the disadvantage?
Post-operatively, sir, patients usually have vasospasms or more. Sometimes that is an issue.
Okay.
Raised cerebral edema by infusions, intra-arterial.
No, intra-arterial, you are going through, say, a femoral route. You
Yes.
go there and you release some nimodipine or milrinone.
Yes,
What
sir.
is the disadvantage?
Sudden
What is Steele phenomenon?
Steele phenomenon.
Dr. Vedang, want to give it a try?
Reperfusion injuries can occur.
No, reperfusion can definitely happen if they dilate. What
Yes.
usually happens is if they are going with an intent to coil, they'll have to reach right till the base of the aneurysm, right? I do not know whether you have actually seen it
Yes, sir.
sometime. By and large, when they are going with an aim to inject a vasodilator, they would probably release that vasodilator at ICA bifurcation maximum or sometimes within the cranial ICA trunk. So what happens is, because the vasospasm earlier is more in the vessel which has got an aneurysm, less dilator goes there, the more dilator goes say on the ACA side. For example, in this case there is an MC aneurysm, so the ACA will dilate more with it having more vasodilator, and the MCA territory would rather get hypoperfused. So that's the disadvantage. You understand this point?
Yes, sir.
What else? There are like phases of vasodilatation or vasospasm, right? There is a pharmaco-responsive phase and a pharmaco-unresponsive phase. All these are part of the answers of question 2, man. Pharmaco-unresponsive phase, what do you do actually? Is there a way, or you give up and let the patient go into infarct?
That modality which you can do, I mean, it is not responding to the standard intra-arterial nimodipine or IV milrinone, whatever.
I'll give you another hint. It is a major vessel spasm.
Yeah.
Then what do you do in those cases? See, we will keep on cribbing that all the aneurysms are going to intervention. When you don't know yourself anything about intervention, then obviously the intervention people will take it over, right?
Or intra-arterial balloon dilatation.
Yeah.
Okay.
So that is mechanical dilatation. What else? What is the one most important key factor in this case which will prevent vasospasm? The one most important key factor in this case. What do you have to do in this surgery? Absolutely necessary.
He's already pointing.
See, I'm already pointing to the answer
Pointing
also.
to it, yeah.
Decompressing with the evacuation of the bleed, sir.
Once you go to the
Absolute
catheter,
evacuation of hematoma is paramount in this case.
the blood which causes irritation and
Spasm.
yeah.
Sir, I think for the want of time, it's already crossed 6 o'clock. We'll
Yes, sir.
let the other two OSCEs be. And you can judge the candidates, both of you, sir, according to you. What do you feel about
We'll text you whatever afterwards.
You
No,
can
no,
just
sir,
tell them, sir.
feedback to them. Feedback to them.
Feedback to them, how they were and what they can do to improve it, because it was a very nice academic session. And I think every 75 people had joined, and I'm sure they had a great learning experience. But these two people who had presented, what's your feedback to them? Both of you first.
Darpan, you would like to say something first? Dr. Darpan?
Yes, I think they presented nicely. The only thing is that there's more to Dr. Vedang than to Dr. Avinash. When we are presenting symptoms, we have to try to go to the disease from the symptoms. If you try doing a retrograde exercise, it's not good. And that is why sometimes in the exam, knowing the diagnosis is a very bad thing to have.
Yes.
So you should not try to fit things into a template. That's it. Otherwise, it was a nice presentation. You have by and large covered the points which were essential. Your analysis was good. So that's the only thing.
Thank you, sir.
So and
Apinder,
you
sir?
complete it, comprehensively cover it, so that you know that there is no other. For example, if there is something on the for example, you are presenting a CBJ, so lower cranial, cerebellum, upper cervical cord, they are all a part of it. So it has to be comprehensively covered, whether taking a positive history, negative history, or when you are examining the patient. That's about it. Otherwise, it's a good, decent presentation. And in fact, also you did well for your bit.
Thank you, sir. Thank you for joining us, and thank you for being a great examiner. Apinder, sir, your take on both of them?
Yeah, so I would like to say that both of you were good in your own case presentations, but both of you were, a bit of silent on others' case presentations. And extempore, you need to have little, so that's the method which we adopt, that you need to answer others' questions better than, because you have prepared your own question. That is not going to happen in your exams. You don't know what case you're going to have in your life, right? So you have to be more proactive in answering others' case precisely. But it was the reverse which was happening. The person who was presented, he was the only one answering the questions.
Yes, sir.
Agreed.
So that widens your, thought process.
Yes.
Yes, sir.
Yes. Thank you. Thank you so much for joining us, sir, both of you.
Thank you.
It was a great discussion.
Thank you, Dr. Prashant and Dr. Harsh.
Thank you, Dr. Prashant.
Thank
Dr.
you,
Harsh.
Dr. Darpan. Thanks for being.
Thank you, sir.
Thank you, sir.
Thank you, everyone. Thank you.
Thank you, guys. Thank you, Vedang, and
Thank you, Vedang and
all the best
Avinash.
for your future.
Thank you, sir. Thank you. Nice.
Thank you.
Bye.